Hi, good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note we are recording these sessions for later distribution. Know that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, an email in the chat function to help us with our record keeping. We appreciate your support in fully capturing this record. We love to see everyone's smiling faces, so if you're comfortable and able, please do join us by video, especially for the discussion portion of today's session. We invite everyone to speak, but ask that you stay muted unless you're speaking. To mute and unmute, select the microphone icon on the bottom left of your screen. If you've joined on a computer or if you've joined on a phone, use *6. You can also communicate using the chat feature to raise questions and share comments. Please note that no protected health information is allowed in either the chat or our discussions. During and after the session, the Shout Echo team will send out a link to the evaluation for the session. We appreciate you filling it out to provide us some feedback. Our didactic today is on harm reduction and building patient rapport during hospitalization. Following that, we will discuss a case presented by Dr. Elena Jimenez Gutierrez. We will start with some introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again today for joining us. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. So we'll do some introductions right now. Dr. Moriartis. Oh, okay. Sorry, we'll let you finish what you're eating.
No, fair enough. I just took a giant bite because my name is Brady. I'm a hospitalist. I'm on service. We finished rounds like 5 minutes ago. And I'm part of the Shout Texas team and happy to join you today.
Thank you so much for joining us. Dr. Ramesh.
Hi, I'm Dr. Ramesh. I'm one of the hospitalists over at DelMed.
Thank you, Dr. Ramesh, for joining us. Alana?
Hi, everyone. I'm Alana Bolton. I'm a program manager at DelMed, specifically over our Shout Texas work, which is why we're here today. Thanks so much for joining us.
Thank you. Claire?
Hi, I'm Claire Zagorski, and I am a program coordinator and harm reductionist at UT Austin's College of Pharmacy.
Thank you so much for joining. Dr. Gutierrez?
Hello, my name is Elena Jimenez Gutierrez. I'm one of the hospitalists at UT Health San Antonio, and I'm glad to be here with you.
Thank you so much. Since it's a small group, we'll go around with introductions today. We have Megan.
Hi, my name is Megan Clark. I'm a PA. I currently work for UT Health in Houston at the Heroes Group.
Thank you. Andrea Rocha.
Hi, everyone. Andrea Roche here at UT Health San Antonio. I'm the ECHO program manager. Great to be here.
Thank you for joining. Andrea Hebler.
Hello, my name is Andrea Havler, and I'm one of the project coordinators for the ECHO sessions. I'm happy to be here.
Thank you so much. Emily.
Hi guys, I'm Emily Bada. I work in Houston at Ben Taub Hospital. I'm a nursing program manager for our maternal substance use program.
Thank you. Kristen.
Hi, I'm Kristen Jansen. I'm faculty at the College of Pharmacy here at UT Austin, and I'm also an internal medicine pharmacist at Dell Seton and a member of our B team.
Thank you so much for joining. Sean.
Hello, Sean Wright. I'm the program director for recovery support services at Abilene Recovery Council.
Thank you, Sean, for joining. Martha. Martha, are you able to unmute and introduce yourself? We are not able to hear you. So perhaps you could just type your name and affiliation. Thank you. Grace Diaz?
I'm sorry, I had to step out. Yes, ma'am. I'm Grace Diaz, Director for MedMark in El Paso.
Thank you for joining us.
Thank you.
Araceli?
Hi, yes, I'm here in Laredo with Concilio Hispano.
Thank you for joining us. William Thomas? William, are you able to unmute yourself? Okay, we'll come back to you. Rhoda Hall?
Hey guys, my name's Rhoda Hall. I'm with Permeate Care. I'm a PAC counselor in an LCDC.
Thank you for joining us. Relias? Are you able to unmute yourself and introduce? All right, we'll come back to you. Corey Armstrong? Please unmute yourself.
Can you hear me?
Yes.
Yes, my name is Corey Armstrong. I'm a peer support specialist with Permeate Care.
Thank you for joining us. Adrienne?
Hello, Adrienne Lindsay, Director of our Telementoring Institute here at Texas Med. Thanks, everybody.
Thank you for joining us. Carmen?
Hello, Carmen Harris with Permeate Care, Substance Abuse Director for Region 9.
Thank you. G. Botello? Please unmute yourself. All right, we'll come back to you. Dustin?
Hi, Dustin Amos, Associate Professor at University of North Texas Health Science Center in Fort Worth and Medical Director for our JPS Inpatient Psychiatric Hospital and helping lead our Shouts team here at JPS in Fort Worth.
Thank you so much for joining. Jade?
Yes, Jade Womack. I'm the CCBHC manager. I work for Permeate Care and we're in Odessa in Midland.
Thank you for joining. G. Botello?
Yes, my name is Lupe Botello in Laredo, Texas. Can you hear me?
Yes, yes, we do.
Okay, I'm a program counselor with Methadone Clinic here in Laredo. And good to be here.
Thank you for joining us. AAMA CHL? Are you able to unmute yourself and introduce? Okay, we'll come back. Dr. Hill.
Hey, y'all, I'm Lucas Hill at the UT College of Pharmacy. I have the pleasure of working with your expert first speaker today, Claire Zagorski.
Okay, thank you for joining us. Tony Lopez. Elizabeth Sanche.
Hi, I'm an OBOT counselor with Texoma Community Center in Sherman, Texas.
Thank you for joining us. Grace Bolano.
Hello, my name is Grace Bolaños and I'm with the TMF Health Quality Institute. We are the quality improvement organization for the state of Texas and contracted with Medicare.
Thank you for joining us. Justin.
My name is Justin Ortholagi. I'm an LCDCI and the COPS-D specialist with Permeate Care in Odessa.
Roberto Garza. Dr. Patel.
Hey, this is Snehal Patel at Del Med School. I'm one of the hospitalists here.
Thank you for joining us. In the interest of time, I will have to move on to our next segment of our session. Please do write your name and affiliation so we can capture everybody. Thank you. So we'll move on to our didactics. Claire, you may take it away when Echo IT shares the presentation.
Sounds good. Thank you. All right. How does that look, y'all? Okay.
Looks great. Thank you.
Wonderful. Thank you so much. So my name is Claire Zagorski. I introduced myself earlier. I'm a paramedic and a harm reductionist. I've been doing that for about 8 years now. And I work at the University of Texas at Austin College of Pharmacy in the Pharmacy Addictions Research and Medicine program. And our director is Dr. Hill, who's on the call today. So I'm going to talk today briefly about developing rapport with patients who use drugs. This kind of stemmed out of a discussion we had on another Shout Echo a few months ago, where some of the debate and the discussion got going into like how to deal with interpersonal issues when there's power struggles with patients who are perhaps withdrawing from drugs and really uncomfortable. So I just really wanted to combine some of what I've learned, because I have a lot of luck with this. I wanted to combine that with some of the research on stigma and patient healthcare provider interaction to just try to come up with some really simple and actionable steps for y'all today. So my position is funded by SAMHSA and Texas HHSC. My opinions today do not necessarily imply endorsement by the government of either the US or Texas. Gotta say that, right? Okay, cool. I'm gonna dive on in. And I want to consider very briefly the context of where we're coming from. There's plenty to say about developing rapport with patients writ large, but this is a slightly different population with different needs and contexts. So poor rapport, poor trust, interrupted trust with patients who actively use drugs is super, super commonly reported in healthcare settings, both on the patient side and the provider and healthcare team side. So it's, when you see it kind of going and going, you're like, what's going on here? Part of this is something that I have personally observed a lot. I spent about 9 years working in the ER, but also this is something that's been well hashed out and described in a couple of different ways in the literature. It's really a feedback loop that we see, but more specifically, it's termed a causal loop. So this is something that's been mapped by a few different academics. And it really roots in stigma. That's the thing that kicks all of this off. And I know that stigma is an issue near and dear to our hearts, and that's something that Dr. Moriarty and his colleagues have spent a lot of time and effort trying to push back against. But if you start in this context where there's stigma against people who use drugs, and I abbreviate PWUD in this slides just for efficiency. If you start at that point, then we get negative healthcare experiences right away. With every additional negative healthcare experience where the patient experiences stigma from their team, they're going to get less trusting and more guarded every time. And then that comes out into this kind of hostile, intense interaction with healthcare moving forward, which further reinforces back to the healthcare team that this is an unpleasant person to work with. And then they will withdraw from their healthcare participation. And then we get healthcare providers frustrated in that. And it really just snowballs into this mess. So there's this loop going on that has this really observable and predictable feedback cycle to it. So I want to talk about some of the things that are really undergirding this and some simple ways that we can take with us to really interrupt that feedback loop and start investing back in a positive relationship with our patients who use drugs. And I'm going to talk a lot about this in terms of an investment, because I think that's a great way to conceptualize of it. So I want to give a little bit of context to help us move forward. I know we know this, but it's really important to remember, we see a patient in the clinic or the hospital, that is like 1% of their lives. And that is a very brief cross-sectional snapshot that we're seeing of them. And that's an important thing to remember, because it's really easy to take that 1%, that brief interaction, and then expand that to our entire concept of that person. And from there, our entire concept of the population which we identify them with. At the same time, I think it's really important to remember that if we have someone coming to us with a diagnosable substance use disorder, that patient is a lot more likely, simply in terms of statistics, to have a history of mental illness, but especially childhood abuse and neglect. That's one of the strongest correlations that we see here. And even outside of a clinical setting, that patient is going to continue to experience stigma basically everywhere they go. They experience stigma from physician and nursing teams, from the receptionist at the front desk, from the pharmacist, from the EMS who brought them there. And then even outside of a healthcare context, it continues. So these are people that have some kind of pain going on in their lives in one way or another, whether it's physical, psychological, emotional, or so on, maybe a combination of the above. Here in Austin, particularly, we have a really large community of unhoused people who use drugs. So that's an amplifier to this stigma, right? So now we have two different domains in which we tend to think negatively with pre-assumed notions about the population. There's very little money, there's very little consistency, a lot of dehumanization, a lot of stress that we simply don't think of because we're really lucky to not have to deal with it. So I want to start off all of this by priming my audience that this is a population that does not have it as easy as most of us. They probably have a lot of pain in their lives, and we need to really give them some slack. Just priming that in there. So what I talk about this a lot, and what I tend to hear over and over again is, well, that's well and good. Yes, that's sad, but these people just need to suck it up and get clean. Well, fair enough. So let's look at the context there. So public insurance does not cover the gold standard of medication for opioid use disorder, which is methadone. And I think most of us know that. I know there's a couple of folks here on the call that are from OBOTs. And so we know the issue, just kind of some of the policy and contextual issues facing methadone. That's a whole other discussion, of course. Here in Austin, we have a public methadone clinic, which is great, but it has over a 1-year wait list. If someone comes into a moment where they're like, I want to go for it, I want to try to get on methadone, I want to have, positive forward progress in my life, that is not a moment that they're going to hang on to for a year plus. We need to be able to act within hours, right? And even once we get into that, that's, we're looking at a daily visit to a methadone clinic because of their, regional limitations and how few there are. Plenty of people in Texas have to drive hours sometimes to access them, and that's a daily trip. So this really interferes with one's ability to hold on to a job, to take care of loved ones. And we really put people in this impossible situation of having to tug back and forth between, am I going to continue this medication that is helping me avoid use of street drugs versus, am I going to get to work on time? Am I going to get fired if I do this again? So on and so forth. So I really want to emphasize and remind everyone on the call that we make it obscenely hard to just get clean. So we really need to extend some patience and not try to assume immediately, which is very easy to do, that the patient in front of us is just kind of being obstinate. And yeah, when we have a patient population that's routinely excluded from being able to access medical care, and when they do access medical care, it doesn't go well, or maybe they hear rude comments or calling them names, yeah, these patients are unhappy and they don't really trust what's going on. I think that's a pretty reasonable and logical kind of human progression of emotion there. So I'm going to talk a little bit about the roles within healthcare and ways that we can, push back against this and be better. So it's really, really easy to fall into the trap of assuming that your patient is just being difficult and you don't want to have to deal with them. And that's especially easy now when we're all incredibly stressed and taxed with COVID and everyone is really on their last frayed nerve. It's so easy to lash out at our patients. And I want to just extend the compassion there to the teams in the clinical environment who are having to deal with that right now. And I know that this is a big ask to find even more compassion and even more love when our healthcare providers are not being treated with love. Having said that, there is a lot that can be done with simple steps that you can model for your team. And I say this having seen it, and it's been fantastic. I encourage every single one of you to give your patients the benefit of the doubt that they are not trying to make your life harder and they're not being lazy or bad patients. and set an example for your team to act that way, to model compassion and to lead your team in modeling compassion, and make it clear that that's what you expect from your peers and your team. Every single time that you model this, every single time that you extend kindness, compassion, love, respect, a sense of humor to your patient who uses drugs, you're going to catch them off guard in the best possible way. They're going to be so incredibly excited that they have a compassionate person that they can talk to and trust in front of them. And even if you don't get that, even if it's a really rough day and they treat you poorly anyway, that reaction is not about you. And the more that you can invest into a positive relationship with these patients, the better it's going to get next time, the better it's going to be the time after that, and so on and so on and so on. I really think of this in terms of investment. If it helps, you can think of this as promoting healing on the emotional side. But what does that mean in a more specific sense? So I do have an example here in a minute where we have an inpatient context that mirrors what I heard a couple of months ago when I first started talking about this. So what does that mean when you have a patient in the bed in front of you? So it is still absolutely your role to communicate expectations and boundaries, what is and is not okay from the patient's side. At the same time, I find it incredibly helpful to go out of your way to explain your rationale and why you're doing the things that you're doing. Because if you're a patient who's used to being treated not great in the healthcare setting, it's really easy to assume that if your nurse comes in and says, we're not doing that, that they're making that choice arbitrarily, as opposed to based on a clinical rationale. So I find it really, really helpful and important to explain that. And I'm going to give an explanation here and an example in a moment. And another thing that I've seen be a huge trap is power struggles. So there is a power dynamic when we have a patient who's admitted in the hospital versus the team that's caring for them. This patient may want to leave to go smoke, for example. That is often not allowable. That's often something that we tell the nursing staff, no, you can't let them do that. So we get into power struggles there, right? Maybe they want an additional medication or more medication, and that's not part of their orders. And we get into these power struggles back and forth. Some of the things that we struggle over are very significant clinically, like medications. Some may not be, like, can the patient step outside and stretch their legs? Even if you can't see them, is there a way to maybe make that happen? Maybe not. So I really coach people to try to look for ways to give up a little bit of power when it doesn't actually matter. The more that you can flex and more that you can demonstrate your willingness to cooperate and give up a little bit of power, because in the healthcare context, we have it, the patient doesn't, the better we're going to do going forward. So here's my example that I keep alluding to. I'm going to try to whip through this quickly. All right, so we have a patient admitted to med-surg, and they mentioned to you that they want to have a friend bring them some heroin because they are really terrified of opioid withdrawal, really don't want it to happen. So we can't have people bringing heroin to the hospital, right? What is this patient actually telling you, though? Does anyone want to guess? Like, what are we hearing? Are they really telling you that they want to have a friend bring heroin? I don't know that I can see that. Oh, there it is. I'm going to leave, but I don't want to. They need support. Yeah, definitely. What I hear when I hear this, and I've seen this happen a lot, they don't want to go through withdrawal. They're saying, help me with that. But your patient in the bed, especially if this patient is someone who uses illegal drugs, has probably never heard about the good clinical options for help staving off withdrawal. We are not great at treating withdrawal well in a way to keep our patients comfortable. So this is probably not a known value to them. What they're really telling you is that they're afraid of withdrawal. And of course, this becomes a clinical matter that is going to be up to the judgment of the prescriber. But, since we're talking about shouts, I got a plug. Can we order buprenorphine for this patient to help literally interrupt the symptoms of withdrawal that we have going on? And I know that that becomes a policy issue depending on your specific facility, and it's simply not that easy. But I really do want to encourage that. It's a really powerful way to keep our patients relaxed and more comfortable so they can focus on whatever they were there to do to begin with. A patient who's in withdrawal is absolutely miserable and can focus on very little but that, and that makes it harder for everyone. It's harder for the nurse, harder for the physician, harder for the patient. If we can roll out some medication options to help make them more comfortable, let's do that. Let's talk about that as an option. So we could do that. And even if buprenorphine isn't a possibility for, facility policy reasons, we can also try medications to try to relieve some of their symptoms. Can we treat that diarrhea? Can we treat the body aches? And can we treat the anxiety? But I know a lot of you know that the default on this is we're just going to kind of let them cook, because until it is, opioid withdrawal is not life-threatening. But a really great way to approach this from a communication angle is to explain what the options are. Lay out that menu for them, explain what we can do and what is absolutely not going to happen, but lay it out in an impartial way that doesn't impart judgments, because you may not approve of the fact that they use drugs, but that's really not going to be solved right now. And it's incredibly impactful to bank trust and bank good feelings by simply expressing that you understand that they're afraid. You understand that that sounds miserable and awful, and you want to advocate for them as much as you can. So the typical response that I hear from this is anger mixed with a dash of incredulity. Like, what is wrong with you for even telling me that? You're not bringing that bullshit in here. I'm going to call the police if you tell me that one more time. And then we'll have security watch them, right? So that's not a good feeling. You basically said that you aren't hearing what they're telling you. You assume that they have bad intent and they're going to try to sneak something by you, and then we're going to surveil them. This is an ugly feeling. It does not feel good at all. And it really wasn't necessary, because that really wasn't what the patient was telling you. They were just telling you that they're really afraid and are going to go to lengths to avoid this sensation. How else could we approach this? So the bottom line is we want to advocate for our patients all the time. We want to do whatever we can to make them comfortable and make this a positive, a growthful, good experience where they can get better. So instead, say this, use your words, say that, wow, you really don't want to go through withdrawal. And I understand that, because that sounds really awful. So here's what we can do. I'm going to go talk to your doctor about what some options might be. We might be able to try some medications to help stop withdrawal from even showing up in the first place. But if it does happen, make it way easier to get through. However, it's still absolutely your job and your right to lay out things that can't happen. Boundaries are always boundaries, and that doesn't change here. You can lay out your boundaries in this situation and say, it is not okay, though, for you to bring illegal drugs into the hospital. You will get in trouble, your friend will get in trouble, and it's not safe. So I need you to be clear that we can't do that, but I do need you to know that we're going to advocate to try to find a better alternative. Makes sense, right? So that's a feel-good interaction where you're banking trust. They're going to be surprised that you're going to do the extra step for that, to really try to find a better solution, because the default at this point is this. This is what people are used to hearing. They're basically used to being told that's not going to happen. You're an idiot for bringing it up. Be quiet. We can show empathy in this scenario really easily. We can lay out what is possible versus what is absolutely not possible, and let them know that we're going to try to meet them halfway as much as we can. All right, some other things that we can do here. Ask questions about drug use. We tend to be kind of sketchy, or not sketchy, that's not the word I'm looking for. We tend to be kind of cagey about it. We get a little anxious talking to people about their drug use, maybe a little bit embarrassed. It reminds me a lot of how we can be nervous talking to our patients about their sex lives, for example. Like, it feels a little iffy to talk about it all. We carry that with us, and we need to let that go. This is a thing that's a known factor in our patients. If they're telling you that they are using drugs, or perhaps they're admitted for something related to that, then this is a known. So go ahead and talk about it, because it's relevant to their care. You can ask, what do you enjoy about your drug use? I love this question, and people tend to really raise eyebrows when they see it, but anyone who uses drugs enjoys it for some reason or another. whether they enjoy it because it is the only thing that gets them out of pain, or they enjoy it for more like nebulous and recreational reasons. There's something in there that motivates them to continue using drugs, even if that's simply that it avoids withdrawal. That's still an enjoyable thing. And that helps you better understand how drugs fit into their life and to see if there's something that we can intervene with medically to help them, I'm sorry, or to help them get to a better point, or maybe address an unseen medical issue. We can also ask about our goals, and that's something that's kind of baked into ASPERT, which I know a lot of us know about, but also, don't make unfounded assumptions. Not everyone wants to stop using drugs. Drug use, recovery, relapse, rehabilitation, this is usually a very winding and long road for people. And for big chunks of that road, some people may not want to stop using drugs at all. I know a lot of people that don't. They may or may not get to a better point, but that's not something that you can really force in the hospital, right? So any kind of positive change counts, and that's a big thing in harm reduction. Maybe we can figure out a way to help them use a little less frequently, or maybe use in a different way that's safer for their body. And there's a lot that can kind of go into that. But, we were just talking in the huddle before this with Dr. Moriarty's about, the perfect being the enemy of the good. And I think that's a big thing in harm reduction. Just because we're not going to go from 0 to 100, from disordered drug use to total abstinence, that's not going to happen immediately. It's just not. But that doesn't mean it's not worth trying to progress up that track a little bit, right? Also, don't take things away if you can't replace it with something else. And this is something we hear a lot from pain patients, for example. They may be deprescribed from their from their medication for chronic pain without an alternative. And then we hear people talking about how they'll start sourcing illegal drugs, for example. So it's always important to think of it in that way. The drug is serving some need. You got to be able to replace it, whether it's with a drug or something else. And that's why it's fun to be creative in healthcare. And remember, this patient has a chronic remitting and relapsing disorder. So think of it that way. It is so worth it to choose kindness. Sometimes it's really hard to muster. I worked in a really busy ER for 9 years. I know how grinding and exhausting it gets. It's really worth to try.
So I think there's like the usefulness of I remember talking to y'all early on, part of the impetus for this study was to use it as local motivation with it.
I thought he was asking me a question. Where was I? So yes, so try to choose kindness as much as you can. You really think of this as an investment. Every single time you can show your patient that you're different, that you're compassionate, and you're going to do whatever you can to advocate for them and meet them where they are and model that for your team, it pays off tremendously. So the reason I keep saying this, I've spent the past 9 years or so working directly with people who use drugs on the street doing wound care. And I am tremendously busy doing that. And what I tell people is that while there isn't a whole lot that I can do in terms of longitudinal care of wounds that get complicated, we end up punting a lot of them to physicians. One of the really impactful things that I get to do is pose as a positive interaction with healthcare for my participants. That all on its own, that incredibly simple thing has been so incredibly valuable and as an investment in these people. So this is an example that I like to put up. So this is one of the participants. We worked together for about 6 months on a few different things. We worked on a couple of wounds, and eventually we got her in to start on methadone. We had a brush with sepsis at one point. There were a lot of complications going on here. But at this point, they finished college. They graduated with honors. They now have a fantastic job. They ended up leaving their partner, who was abusive and very reinforcing of some of the worst impulses that we had here. And they are still on methadone, still not using heroin, and have really just are so much happier, so much more productive. And I've never seen her so happy. And honestly, this was really simple and straightforward. It was just me being really nice and listening and just being there. And I have a lot of other examples, but I only gave one. So I really can't say enough about that. Really try to reframe this and think in terms not of, this being a contentious interaction, but a patient that needs some support, a patient that needs some resources, and that you can be there to help them feel a little bit better and a little bit more trusting of the system moving forward. So I will go ahead and wrap up. This is my email. Please feel to reach out at any time. If you're interested in learning about harm reduction more specifically within Texas, harmreductiontx.org is your resource. They have a statewide alliance and you can get a lot of great resources from them. And if you're interested in some free CE on this general topic, txoti.org is your place. All right, I will wrap up.
Thank you so much, Claire, for that excellent presentation. This was really amazing. I'm sure everybody enjoyed it. We will move on to quick announcements before the case. Echo IT, thank you. Next slide, please. So Texas Mood has a network of providers for medication treatment, a network of recovery support services, also provides hospital-based opioid use disorder screening and treatment. Texas Mood provides telementoring through various programs, including Project ECHO, Get Favored Texas, and Texas Substance Use Symposium. There are several ongoing clinical trials as well. Next slide. Shout Texas is a program at Dell Medical School at the University of Texas at Austin and UT Health San Antonio's Texas Mood that is working to increase access to substance and opioid use disorder treatment and harm reduction during acute hospitalization. We have monthly echoes, monthly generally focused virtual office hours, quarterly obstetrics and postpartum focused virtual office hours, and an expansion pilot program. Next slide. Our next Shout Community of Practice Echo is on January 20th, 2022. So please do join us. We have some exciting speakers lined up. Next. The Beeville, Texas Clinic provides access to free evidence-based treatment for addiction recovery and mental health well-being. Please visit recoverytexas.org for more information. Next slide. They provide addiction medicine services, counseling, and peer recovery support. Next. Heroes Helpline provides a free, entirely confidential telephone support and referral service that affords first responders and healthcare workers the opportunity to seek treatment without fear of judgment. Next slide. For more events and resources, please visit our website, shouttexas.org. Thank you. Thank you. Now we will move on to our case. Dr. Jimene Gutierrez, please take it away once Echo IT shares it on the screen.
Thank you. Thank you very much. Can everybody hear me?
Yes, we do.
Thank you. And I apologize, I don't have a beautiful background as Dr. Zagorski. And thank you so much for that wonderful presentation on being more compassionate and reducing and harm reduction and decreasing stigma. This fits really well with what I wanted to talk about today or represent in terms of my case. This was, and I'll briefly talk about this 40-year-old man who had recurrent hospitalizations in the setting of heroin use disorder. He was coming in, I think his third or fourth admission for MSSA, for methicillin-sensitive Staphylococcus aureus bacteremia, complicated by seeding in multiple parts of his body. He had severe tricuspid regurgitation, a very large vegetation, as well as evolving discitis, osteomyelitis, spine, and he had resulting septic emboli to the lungs, and some. This was also in the setting of some chronic lower extremity wounds that had failed previous grafts from plastic surgeons. So he unfortunately was coming in with sepsis, and the reason why I wanted to focus more on system levels based or system level changes and seek all of your expertise and guidance is because I felt throughout this day we had several system level barriers, and we also had many interactions with different levels of healthcare professionals who I think were imbued with stigma and discrimination towards him, given his recurrent hospitalization, and there was rising, I think, frustration from the providers and from the patient as well, with his care and our failure to really truly help him. This is in the context of our hospital does not have a current MAT program, so we don't have any any medications for opioid use disorder that can be provided inpatient unless you're pregnant. So going forward, the questions I would like to be addressed by the Shout Echo community of practice today: how may hospital-based pharmacists, nurses, and social workers influence and support development and implementation of inpatient MAP programs? What are recommended strategies to decrease stigma in relation to opioid use disorder within an ED and an emergency department or inpatient setting? And what are strategies to prime a hospital's culture to receive that MAT program? And what have been the lessons learned in equipping hospital-based pharmacists, nurses, and social workers to educate and encourage patients regarding these programs? So our current situation, current state at the hospital, between May 2019 and May 2020, University Hospital had close to 3,000 patient encounters carrying a diagnosis of opioid use disorder or poisoning, and roughly a third of these patients presented with these diagnoses were subsequently admitted to inpatient care. There's currently no buprenorphine treatment protocol for patients with opioid use disorder hospitalized at University Hospital. And success to us would be the implementation of a comprehensive buprenorphine treatment protocol for patients with OUD presenting to the ED and or hospitalized at our institution. And this would entail a seamless transition from the ED to the inpatient wards with successful initiation of buprenorphine and a smooth transition to those medication-assisted programs and support services in the outpatient setting once we discharge them. So questions I have, I think I've went through those. So basically, how can we support developments, implementation, decrease stigma, and what lessons have you learned in this process to educate and encourage patients? In terms of options that we have currently for addressing the situation, we have continued involvement of our supportive psychiatric, ED, and internal medicine hospice champions. We have tailored training opportunities and educational materials for the personnel involved. We are in the process of creating more. I think the ED is taking a lead on that currently. We have continued to encourage our clinicians to obtain DEA-X waivers, but we haven't had much success in getting them to be X waivered. Another thing we're working on is the development of buprenorphine administration protocol for patients in the ED and the inpatient setting. The ED protocol, I think, is actually already in its almost final version, and we look forward to creating one in the inpatient setting. Regarding obstacles that we have or may come across, as I said, buprenorphine is restricted to inpatient use at our hospital for continuation of therapy in pregnant women on buprenorphine maintenance therapy. I have been told that this might change within the next month or two, and I really look forward to that change to expand our services for inpatient population. Barriers related to health insurance coverage, as were mentioned during the previous presentation, reimbursement and payment policies that do not incentivize the provision of medications for opioid use disorder. Inadequate professional education related to the evidence-based for MAT, and lack of waiver providers, stigma in relation to OUD, and reluctance to organizational change in some of our workflows to incorporate that. Thank you very much, and I very much look forward to all of your input.
Thank you so much, Dr. Gutierrez. So I'll open the floor to our learning community here, provide some insights on this.
We have a great group today with a lot of, I think, insights of people at all different stages of this process of trying to set up this program. I want to get us started just because I think the connections between Claire's excellent talk about harm reduction, I think there's some clear connections here that I'll start with, and then really would like to hear others. But one is when we start to think about this implementation, I think it's a common barrier that we run up against is that we're trying, like I noticed some of the words used, you know, success is having a comprehensive plan, seamless transitions, offering to all these people. And I agree that's like success, but we need some successful markers that are closer. In other words, oftentimes we're trying to design these like perfect programs that are going to reach everybody. And you said we're reaching 0 people right now, right? So the goal is to actually start with one person and try with one patient. And you'll learn a lot more about the process. Now I realize upstream from that, you're running into a problem with you can't even try with one person because of the formulary. And that's a major barrier. But the one principle that I'll share around that is similarly, I think we oftentimes as the champion, you know, think we have to bring everybody along. We've got to get all the executive sponsors and pharmacy, and that is an overwhelming task. I would suggest you need an executive sponsor and you need a willing pharmacist. Our B team was, I think, successful largely because we found a passionate pharmacy champion who really pushed from the inside to help us get on the formulary. We found a supportive CMO who really helped us push on the executive side, at least to not let the executives get too much in the way. Honestly, is all we needed. We're like, look, we don't even need money from you. We don't, just like, please don't get in the way. So anyways, I'll stop there, open up, because I think lots of people have thoughts about this, but I just want to start with those principles of like, we're trying to design perfect, we're trying to over-engineer often, or we're trying to convince everybody to write some sort of big policy. And it's more like, let me prescribe Bupe to this one person, let's see how it works. And let's get a success story, which really helps with the stigma reduction, is just highlighting those outcomes as positive stories.
Thank you so much, Dr. Moriatis. I believe we have Kristen Jansen here. Would you like to comment on that?
Absolutely. So I'm an inpatient pharmacist, and I was not the pharmacist that he's talking about, but one of my colleagues, it was really one pharmacist in our department who is extremely passionate about this. And I think a lot of resistance in this topic comes from people being scared because they don't know what to do. I think that there's this perception, especially among pharmacists, I'll tell you, like, we are rule followers as a general group, like we like black and white things. And because of that, I think there's a lot of, and when I talk to other pharmacists, they don't understand the laws because I don't think we spend a lot of time discussing them. It's not something you focus on in your training. They don't ask a ton of questions about it on your law exams. And I think having one person that can help kind of alleviate some of those misconceptions, who understands and kind of talks in that same language, because I'm guessing most of y'all have not extensively studied pharmacy law, because oftentimes the dispensing part itself is scary because it seems like if you just superficially look at the laws that it could be potentially illegal, and it's not. But I think having someone understand, and that's one of the questions we get a lot of is, well, how are you allowed to do this? And I think there's a big misconception that it's illegal to initiate treatment in a hospital when it's not. I think the other thing too is, you're exactly right, having algorithms, things that people can look at and help feel comfortable when they've not done this before and haven't had a lot of opportunities to do this in their training, helps people feel a lot more comfortable. And I think when it was a colleague of ours named Kirsten, who we have a very similar name. But when she started doing this and she started presenting to the other pharmacists at our site, I don't think anyone was necessarily against it. I just don't think they felt comfortable and confident treating patients and initiating buprenorphine because they know that it has some properties that are a little different, but they were afraid and it didn't seem approachable or accessible. And by breaking it down and talking about like, let's go back to the basics and talk about the kinetics of these medications and, you know, all those things that pharmacists care about, I think that really helped. And now it's not an issue. You know, if they don't know what to do with something, they know that they can reach out and ask. But I think people aren't scared of it anymore, which is one of the reasons why we've been able to have success and buy-in. And I think because of that, it also changed some of the stigma.
Thank you. I think I just want to follow up on that, kind of take a segue, because you mentioned, how do we kind of engage the stakeholders involved? Like, how do you get everybody on board? And because you explained that the pharmacy law, I mean, people don't understand it. How do you navigate that?
I think one thing, again, having somebody who's interested in looking into this or connecting people with resources, you know, for example, if your pharmacists have questions, like connect them to me, connect them to Lucas, like we are happy to talk to them about it and help alleviate some of those concerns and point them to specific things. I think that's helpful. I think another thing that Kirsten focused on a lot when discussing with the P&T committee to help get this on formulary is not just thinking about the fact that this is the right thing to do. Honestly, you know, sometimes that should be enough, but if we're being honest, it is not always all that it takes. So thinking about not only is this the right thing to do, but we have evidence showing that this is going to reduce hospitalizations by providing it, kind of having those, you know, backup things to say there is also a benefit to the health system by doing the right thing, I think was also motivating to the stakeholders, because we're always talking about how can we reduce readmissions, how can we, you know, prevent when patients are discharged. You know, when we don't have programs in place, we know that when patients have withdrawn and go back to whatever situation they are and do use drugs again, they're at risk of overdose because they've now been taken off of their medications. So I think having those conversations about this is the right thing to do, and there's all of these other benefits that are going to benefit the person, they're going to benefit the health institution. I think honestly, they benefit the providers as well, because you're able to have a better therapeutic relationship with your patient, like Claire was talking about earlier. I think using those as some ways to engage stakeholders who initially might still be skeptical and have some stigma. You can work on here's some data, this is a language that we all speak. And then they start to hear the stories that come from it. I know there's some really impactful quotes that some of our team members have been able to share as they're having follow-up conversations, that they're like, wow, and it becomes personal and becomes real. Like that text message that Claire showed about being with the individual patient, like how could that not move you, right? And you have to get in there first. And sometimes we do that with numbers and figures that, again, are not the highlight of why we're doing this, but it's an important component of it. And so you can start with that kind of hard data and then go in with the real experience, how this is impacting your patients, your staff members, and using that to help continue and get their continued support after kind of that first trial or yes.
I know this isn't the topic of the discussion today, but just to throw on top of that, that as you're communicating, I think especially with pharmacists, Kelsey Coleman, a pharmacist involved with Shout, who one of your programs that's not here today, I don't think, from looking at the list, created the document that I put into the chat just now from some discussions that we had via email. And, you know, it's shocking to me, maybe I've missed it, but that ASAM, that SAMHSA, that nobody has put out like a clear breakdown of who can order versus prescribe buprenorphine or methadone for what indications in what situation. And it's not really that complicated, but nobody lays it out in a simple way, and she did. And so, you know, this reflects our discussion, and I think it helps to point out to a prescriber or to a pharmacist who's maybe standing in the way of a prescriber that when you do have a patient in the hospital in this situation who you need to take care of, who needs to stay for treatment, and you're trying to do the right thing, and the right thing's pretty obviously to start buprenorphine or even methadone, like you can, so you have to, like it's not an option. And this points out in a much clearer way that you can, and we can't hide behind the X waiver thing, because you don't need an X waiver to do an inpatient.
Yeah, I was going to say, using words like evidence-based care and patient-centered care are what administrators need to hear and leaders need to hear. That's what this is. Giving people just basic kind of, tune them up without addressing the substance use disorder that's driving why they're in the hospital doesn't treat the whole patient and isn't best evidence care. So Suboxone, buprenorphine in the hospital, or methadone, or whatever you need to help a particular patient is evidence-based care at this point. It is standard of care at this point. We're basically setting the precedent across the country. It is standard of care, just like Lucas said, if you can do it, which you can, not only should you, but you're supposed to. That's what good healthcare providers do. So does your hospital system want to be giving the best care or just giving like okay care, and not really helping people get better overall? So I think that's also a discussion. And I think everything that's been mentioned is really important. There's like no arguments against. It's pretty easy to use, and there's lots of different reasons from so many different angles. So it's an easy sell. And I think the unfortunate bit is that it's so terribly stigmatized in so many different realms that it's hard to overcome that, but you can.
Thank you so much.
I agree, Blair. I think standard of care is what really caught the attention. Like, that's like saying safety. This is a safety concern to a nurse or something. It's like everybody pays attention, or to a pharmacist. Saying this is standard of care, really, like, the execs get very nervous about that. It's a little tricky because standard of care implies that this is what's happening across the country. And as we've known, there's a big gap. So I think we said this should be standard of care. This is going to be standard of care, and we don't want to be behind. Like, we need to have our processes in place.
One thing that I wanted to mention just really briefly on this, because especially considering the patient presentation specifically. So it sounds like this patient had MRSA bacteremia, right, and tricuspid regurg. So, I mean, those are two things. If we want to talk about baby steps, like if we're, again, there's a big leap, right? Like maybe you have to work with your facility before we can get MOUD in the facility. But you can teach our patients as well. If you were seeing them coming in with infections, abscesses, things like that, you can sit down and coach them on cleaning before they inject. And I know that sounds like the most obvious thing. A lot don't know to do that. You can literally sit down and show them, this is how I clean my skin before I inject into it. I make sure that it's dry. I use this. I don't touch it again. I use a clean needle every single time. Things like that. Yeah, don't lick your needles. Thankfully, that one's going away, I think, generationally. But yeah, so I mean, MRSA, right? So most of those infections that we see secondary to injection are flora on the skin. So it's like staph and strep. So simple things like teaching folks really good, clean injection habits, making sure they know that they should use a fresh wipe every time, they should use a fresh needle every time, and helping them find that out in the community really does go a long way. Like if we're going to have to talk about months before we can get a facility at that point that we've been talking about, where you have to go demand updated practice of care, that's a good place to start. You can help people, like they make filters you can put on needles to help filter out insoluble particulates that cause tricuspid damage and lead to endocarditis. So there's again, I want to come back to Dr. Moriatis's point earlier that sometimes it's just one step. Like we think about leaps. Can you do one step for one patient? Things like that. It's really simple. And it's something we take for granted. It's like day one, what we learn in nursing school, right? Is how to clean before you do injections, small wins, and don't assume that your patient knows it. I can't tell you how much time I spend just showing people how to clean their AC before injecting. It goes a long way.
Thank you so much. This has been an awesome discussion. In the interest of time, we will move on to a summary. Dr. Moriatis, could you please provide us a summary of recommendations?
Yeah, sure. So today I think we had great talk by Claire Zagorski around harm reduction and stigma, and particularly the connection with trust and distrust, which I think were very important, avoiding power struggles, and showing that you're empathetic, willing to flex, and setting boundaries. And I've never asked the question, what do you enjoy about using drugs? I think that was a nice thing to take away as well, as far as doing that. And then we discussed how to build a program and the implementation. And I think, like I said, there were a lot of connections around that same sort of mindset about starting with the small wins, getting people on board who will help you push, and using some language around, this needs to be standard of care, this is evidence-based, and dispelling a lot of myths. Hopefully another takeaway is you should call on Kristen Jansen and Lucas Hill to talk to your pharmacists. They will talk directly to your pharmacist, and that will have huge impact, I think. And then the toolkit so both this document shared and we have an entire toolkit through Shout Texas that has comprehensive information about how to implement these programs, which we can share with you and which will soon be shared publicly on our website. So please use those resources, and we're here to support. And we got to start with one patient in front of us and one pharmacist and one nurse who's going to help us push things forward and share success.
Thank you so much, Dr. Moriartis. Thank you, everybody, for joining today's session. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you at our next session, which is going to be next year on January 20th. In the meanwhile, we wish you a wonderful and safe holiday season. Thank you. Bye.
Thank you.